Welcome to Lively Live Snippet. Hope life is treating you well and you are enjoying it. Today, I will like to share a little about the pharmacotherapy of COVID-19, the current hot topic. Corona reminds me of spikes emerges from snowland just like the trees grow from ground in this picture. If you are feeling unwell, speak to your doctor and healthcare team. Any content in this video is for information only and by no means to substitute any professional medical advices. Kindly refer to the latest findings as many clinical research are ongoing and new data will emerge now and then. Let's celebrate the tentative nature of science together to the fullest.
COVID-19 is derived from the term coronavirus disease, 19 because this disease started in 2019. So, what is the pathogen? Its name is Severe Acute Respiratory Syndrome Coronavirus 2 or in short, SARS-CoV-2. It is from the family of coronaviridae. It is a large single-stranded RNA virus. It has a lipid envelope studded with club-shaped spike proteins as shown in the picture like crown. Since this virus has a lipid membrane, its membrane can be disrupted by alcohol of at least 75%. The next question is, how does this pathogen enter the host cells? Virus can enter via two methods. The first one is pretty straightforward, with the virus fuses with host cell membrane and releases its content for subsequent multiplication. The second method is through a receptor called angiotensin converting enzyme 2 ACE2 on host cell membrane. The spike glycoprotein found on virus particle binds on the ACE2 receptor. Another crucial step is activation by a protease, named transmembrane protease serine 2 or in short, TMPRSS2. After the virus is being taken into the host cell, the virus RNA uncoated and its genetic material being transcribed and translated into protein. After the different parts of virus being assembled, it was being released via exocytosis.
Malaysia government has come out with a guideline and feel free to check out the webpage as shown in the slide for more details and latest updates. According to Malaysia guideline, COVID-19 is being classified into 5 stages according to symptoms, presence or absence of pneumonia, and disease severity. Subsequently, the management was based on clinical stage 2. Stage 1 patients do not have any symptoms. Stage 2 patients are symptomatic, but do not have pneumonia or warning signs. Some examples of warning signs include but not limited to fever, dropping absolute lymphocyte count, ALC, increasing C-reactive protein, CRP, and tachycardia. For stage 3 patients, they usually have pneumonia, and some warning signs. Stage 4 patients are in more serious condition who require supplemental oxygen. Stage 5 patients are critically ill and the disease spread to many organs.
At the moment, no specific treatment is approved. Only limited data are available for experimental agents. Treatment regime recommended in next slide tends to change as new evidence appears. Please discuss with infectious disease physician or infectious disease pediatricians. These treatments are suggested by Malaysia guideline for COVID-19 clinical management. If patient is not symptomatic, he or she does not require any of these drugs. If patient is symptomatic but does not develop pneumonia, hydroxychloroquine 5-day course is suggested with a loading dose of 400 mg twice a day for day 1. Followed by 200 mg twice daily for 4 days. If patient cannot tolerate hydroxychloroquine, chloroquine phosphate 500 mg twice daily can be given. Chloroquine phosphate 500 mg contains 300 mg chloroquine base. If the patient is symptomatic and has pneumonia at the same time, the length of treatment can be lengthened to 1 week and up to 2 weeks. Only if patient has warning signs, lopinavir and ritonavir or brand name Kaletra can be added. The suggested dose is 2 tabs twice daily for 1 week and up to 2 weeks. If patient reaches stage 4 and require supplemental oxygen, both hydroxychloroquine and Kaletra is the preferred combination. If the disease has spread to many organs, Ribavirin or subcutaneous interferon beta-1b may be considered. The loading dose of Ribavirin is 2.4 grams immediately and followed by 1.2 grams twice a day. The dose of subcutaneous interferon is 250 mg per 8 milliunit every other day for 7 doses. Apart from pharmacotherapy, appropriate general care shall be provided. This includes supportive care such as give supplemental oxygen if oxygen saturation is low. Symptomatic treatment for short-of-breath patients is administer salbutamol by metered dose inhaler with spacer. Nebulizer or non-invasive ventilation is discouraged to avoid widespread dispersion of exhaled air. Moreover, nutritional support should be optimized. The fluid and electrolytes balance shall be maintained. Usual milk or diets of children should be encouraged. Healthcare teams should closely monitor vital signs, blood investigations and blood sugar level when needed.
The first group of pharmacotherapies used in COVID-19 is antimalarials. It is used traditionally to treat malaria and certain autoimmune disease. Hydroxychloroquine has an additional hydroxyl group added highlighted in red rectangle as shown in the slide. This slight modification renders hydroxychloroquine more potent and has less side effects than chloroquine. Hydroxychloroquine may be combined with azithromycin, but this use is not recommended in Malaysia guideline. FDA granted emergency authorization for hydroxychloroquine as COVID-19 spreads quickly. Both of them work similarly. Two mechanisms of actions are being proposed. The first mechanism is the antimalarials increase endosomal pH, and this impede pH-dependent steps in viral replication. As viral replication slows down, spread to other host cells reduces. Another proposed mechanism is that both antimalarials prevent virus fuse with host cells, hence, stopping the viral infection from the very first step. Other than that, chloroquine has immunomodulatory effect. It suppresses tumor necrosis factor alpha and interleukin-6 secretion as well as prevent cytokine storm. Despite the potential benefit, self-purchase and self-medication is not advised as inappropriate use can trigger fatal dysrhythmias and electrolyte shifts.
Another group of direct repurposed antiviral drug is lopinavir and ritonavir combination. The brand name is Kaletra. Both of these active ingredients are protease inhibitors. They inhibit aspartic protease, which cleaves structural and functional proteins from precursor viral polypeptide strands. As the precursors are not cleaved to become fully functional, immature and non-infectious virions are produced. Lopinavir is being metabolized by cytochrome 3A4 and 3A5 extensively in liver. Concurrently, ritonavir inhibits cytochrome 3A4. This boosts lopinavir concentrations and prolongs its half-life, enabling lopinavir to exert its antiviral effect longer. Kaletra can be combined with ribavirin to reduce corticosteroids requirements. However, effectiveness of Kaletra remains controversial. Besides, Kaletra is associated with high rates of gastrointestinal disturbances and it prolongs QT interval too. Hence, prescribers and pharmacists shall be cautious about potential drug interactions. Just now we just studied protease inhibitors as antiviral. Another type of antiviral is nucleoside analog. Two examples are ribavirin and favipiravir. Nucleoside analog consists of a nitrogenous base, 1-pentose or ribose sugar without phosphate group. Nucleoside analog inhibits viral RNA polymerase. Ribavirin contains a nitrogenous base and a ribose sugar. Favipiravir is a prodrug and will be activated in the body with the addition of a ribose sugar to nitrogen highlighted in blue in the bottom left-hand corner. So, how does ribavirin works? Ribavirin induce lethal mutagenesis. Firstly, the yellow template RNA is derived from viral particles. It will be reverse transcripted into green RNA strand from 5' end to 3' end. Ribavirin molecules batch pair with the nitrogenous base of the template RNA due to similar nitrogenous base. As the viral RNA polymerase proceeds, ribavirin is incorporated into newly synthesized RNA. Too many mismatched base pairings subsequently lead to the production of malfunction proteins which replicate less effectively. Mechanism of favipiravir is more straightforward. Upon activated by ribose addition and phosphorylated, favipiravir molecules serve as chain terminator. These molecules are incorporated into the elongating RNA strand and transcription halted. Consequently, the RNA being synthesized is shorter. On the other hand, the RNA favipiravir RNA polymerase complex cannot be repaired by proofreading enzymes. This complex will then be disposed of as redundant RNA, eventually giving rise to the viral genome extinction. According to the paper cited at the bottom of this slide, doses required for effective antiviral property might trigger fatal adverse effects such as hemolytic anemia. Despite this drug is recommended in Malaysia guideline. On one hand, favipiravir has side effects such as abnormal transaminases, psychiatric symptoms, gastrointestinal discomfort, high serum uric acid and others. It is not approved by FDA.
Another potential treatment option is non-specific immune booster like subcutaneous interferon beta-1b. It upregulates CD73 found in pulmonary endothelium. Furthermore, it increases adenosine release. Adenosine is an anti-inflammatory molecule which supports the endothelial barrier. It also decreases vascular leakage in acute respiratory distress syndrome, but this alone is not enough to support survival. Currently, this injection is under clinical trial with the code as shown for a combination of lopinavir, ritonavir with ribavirin and subcutaneously administered interferon beta-1b. Let's wait for the results to be released.
We have just discussed the agents used in early phase to fight SARS-CoV-2 virus. As our body fights infection, a cytokine storm might occur because many inflammatory mediators are being released in the process. The immune response escalates to acute lung injury and may further progress to multiple organ failure, which can be a potentially fatal condition. In scenario like this, we need immunomodulators or biologics to tune down the exaggerated immune response, which is also known as cytokine release syndrome (CRS). Biologics are monoclonal antibodies which act against interleukin-6 receptors for patient with cytokine release syndrome. By decreasing cytokine concentration and inhibiting the synthesis of acute phase reactant, biologics can attenuate potentially fatal inflammatory response. Tocilizumab is an example of biologic which is a List A** item which require infectious disease consultant or physician approval and countersign. Common side effects are abnormal transaminases, gastrointestinal perforation, neutropenia, infusion reactions and some more. Another choice of biologics is sarilumab, but it is not listed in Blue Book. Another off-patent, cheaper choice of treatment to reduce inflammation is corticosteroids. They do this by binding to receptors in cytoplasm, altering messenger RNA transcription, and thus, reducing the synthesis of inflammatory mediators. There are some concerns revolving around the use of corticosteroids, as they may delay viral clearance, increase risk of secondary infection, mortality and trigger side effects such as avascular necrosis, psychosis and many more. However, they are indicated in certain patients who are sicker, such as those with severe acute respiratory distress syndrome, refractory septic shock and underlying respiratory problems like asthma or chronic obstructive pulmonary disease. However, this trend may change as new data emerged from the UK clinical trial on the 16th of June 2020. The trial showed that dexamethasone reduced mortality rate of critically ill COVID-19 patients who were on ventilator by 1/3 and those on oxygen only by 1/5. For patients with milder disease, no benefits were observed. WHO clinical guidance will be updated to reflect how and when the drug should be used in COVID-19. At the moment, let's wait patiently.
As a conclusion, re-evaluate current options when new data becomes available. Avoid inappropriate prescribing and hoarding of medicines. Prevention is better than cure. Therefore, wash hands frequently, wear masks and face shields when needed. You are welcome to read further if you are interested. Thank you for watching. What kinds of videos you would like to see in future? Kindly comment below to let me know. If you like my craftwork, click like, share and the subscribe button. See you all in the next episode.